So, good afternoon, ladies and gentlemen. It's a great pleasure to be here. Even though we started 10 minutes late, we will catch the time so that we will have time also for the break in between. It's in the back. And I'm presenting case number 1 from my laptop because the video which is in did not survive internet transmission to Belgium. And so case number 1, in fact, is a patient which works as a nurse in our hospital. And she has symptoms since years. And the symptoms, as you can see, are postnasal drip, pharyngolaryngeal hypersecretion, cough, blocked nose, and some pressure over the midface and eyes. So daily routine case, some unspecific symptoms. And what do you think it is? These are symptoms of some chronic rhinitis, chronic sinusitis probably. Nasal endoscopy showed only signs of mild, unspecific chronic rhinitis. You see, this is the right nose, nothing very special. This was my working diagnosis, chronic rhinitis. But the lady working at our ward was a little bit, worried. What could it be? Postnasal drip, can it be dangerous? And of course, we tried topical steroids. No real breakthrough regarding the symptoms. And after 4 months, also we tried PPI, proton pump inhibitors, no effect. What would you do? Who would go for a CT scan? Who would not go for a CT scan? Please raise your hand. Oh, it's easier. So we went for a CT scan, and this is what you can see. You see a lesion. It's a bit inhomogeneous in the right ethmoidal cavity. If you look at the lamina papyracea, I don't know whether you can see it here, it seems to be intact. What would you do next? Maybe I ask the experts here, or maybe first the audience. You are experts as well. Are there other exams that would be of interest in this case? MRI? Who would go for an MRI? Please raise your hand. Who would not go for an MRI, and why?
I would want other CT scans if they had been made earlier.
Okay, so a follow-up CT scan?
Well, maybe ask if he or she had earlier in her life also a CT scan for a different reason of this region.
Yeah, the patient, it was the first time when she had imaging. And so it's just image number 1. So, in fact, nurse on our ward, something is there, a tumor. She was very worried, very, very worried. And we went for an MR scan. And here you see the MR scan, not a lot of information additionally to the CT scan, but still it has some benign look. Well, we are here on a roundtable about benign sinus tumors. It must be more or less a benign tumor. So, lesion of benign fibro-osseous aspect in the right anterior ethmoid. This was the radiological diagnosis. What shall we do? Wait and see. It does not really look malignant. Who would go for wait and see? Please raise your hands. You all know that you will see a video because I said it. And the video is from surgery. You would wait and see?
No, I would pose you a question. In relation to her symptoms, how would you explain it? Would you say it's really related, it causes your symptoms, or it's just a lucky finding and I don't think it's related to your symptoms? Because also this would be, I think, guiding you in your decision making.
Yeah, she had symptoms of chronic unspecific rhinitis. And this does not at least look like causing their symptoms. And of course, I told her that you have a nasal mucosa problem. You have some mucosal symptoms. They are not dangerous, and you have something there which doesn't look dangerous either. So we could wait and see. I think it would not be wrong to wait and see, depending on the patient's psychological condition and overall situation. And I proposed this to her, but she was very, very anxious. She has a tumor in her paranasal sinus system. And, well, what's the approach for that? Easy, straightforward, ethmoidectomy, tumor resection, and this is during ethmoidectomy, and you see this fibro-osseous lesion. It was easy to resect, but not in one piece because it was too large. You see that we could leave the, not the lamina papyracea, but the periorbit intact. So it was more or less easy to dissect it from the periorbit. There where the tip of the cotyle dissector is, there the periorbit is open. So we had a little bit of orbital fat, but all in all, we managed just to take it out straightforward, not a difficult operation. You see that in these cases we work with the bimanual or forehand technique. So we have the suction in the field and another instrument to do the dissection. Easy, straightforward, did not take very long. It was bleeding a bit out of the bone and it was hard to coagulate the bony tumor. But in fact, easy to take it away. And the patient has got 51 years and histology came back with juvenile psammatoid ossifying fibroma, which is a benign lesion. It's not very common, this lesion. It's in fact a rare variant of a ossifying fibroma, which is found most often in kids, in children. It appears quite often in the paranasal sinus system, and it is a benign lesion, but it has a high known recurrence rate, local recurrence rate, if there is an incomplete resection. Therefore, also in the international literature, it's a clear recommendation to do a resection. If you wait, we know that it will slowly grow. You have to resect it, you have to completely resect it, and this was the solution of this case. These are the post-operative pictures, and you see even a little bit of bone which rebuilt around the lamina papyracea, and this was case number 1. Thank you very much.
Can I ask you a question? If you would follow up on this patient, how would you organize the follow-up? What would be the intervals between scannings?
Yeah.
Or
I do clinical endoscopic controls, which is easy to do because it just has to come down to our office. And I did it 3 months, half a year, and now yearly. And I see her on the ward and ask how she's going. She still has these chronic rhinitis symptoms. And in fact, I also did MR control.
Okay.
Because I don't want to do repeated CT controls, and I cannot see the whole ethmoid as good as I want. So I offered her to do an MR follow-up a year, and then after 2 years later, so 1 year, year 3, just to be sure, because she's a very anxious person.
Cem,
Yes.
maybe give the microphone. Yeah.
As you mentioned, your first option was actually wait and see.
Yes.
That would be also my first option. And in that case, if the patient wouldn't like to be operated because not so anxious, then how often would you scan in such a case?
Yeah, I would probably
because
scan.
then the growth rate will be important. And it was now, for this case, good that you have operated because it didn't came as osteoma, but ossifying fibroma, which could have the potential of growing faster. But that we cannot really discriminate only from the CT. So from the first CT, if the patient wouldn't have decided to be operated,
I would personally do a first follow-up CT after 3 months, just to rule out some catastrophic finding, some osteochondroblastoma or whatever. After 3 months, you cannot, have a big surprise.
Yeah, okay.
And then when it's the same, then I would do it in a year.
Okay.
But the first interval, as a rule of thumb, 3 months, you cannot get wrong, more or less.
Okay. That was my question. Thank you very much.
Because there's a female predilection for these things, 5-1, almost. So there's a female predilection for ossifying fibroma.
I did not find that in literature. Okay. It may be, but I had a look at it and it was not jumping in my eyes, the female predilection.
I thought it was, and I was wondering if that influences your, for example.
But I will have to check. I will do that for the next meeting.
Just a mention, I saw in the CT that there was some kind of remodeling of the papiresia. It was a little bit pushed towards the medial rectus muscle, so I don't think that there was any still dangerous situation, but potentially in the future could be a end-orbital involvement and could be a little bit more tricky for the resection.
Yeah, I agree. So you at least have to follow up. Yeah. Okay, thank you. Yeah.
Is there anybody of you who would consider biopsying this? Why not, or why? It seems for me a simple question, but I know that people struggle with some. If they see a mass, they really want to biopsy it.
Well,
why would you not do it?
Go ahead, please.
I think once you go to do biopsy in such a case, you remove it completely. It has no sense just to take a piece and leave all the rest there, I think.
As it is bone density, you cannot biopsy it. So
I agree, but
yeah, and the effort for going there and do a good biopsy is almost the same effort as just taking it away. It needs half an hour more.
Mm-hmm. Good, thank you. I think the next speaker is Dr. Virkkula from Helsinki.
Good afternoon. Next slide, please. Okay, sorry. Yeah. I found it. These are my disclosures. This case was a young lady, 17 years old, who visited an ophthalmologist for exophthalmos, and it was developed slowly in 2 years. Yes, thank you. Her left bulbous was inferolateral, and she had proptosis about 5 millimeters compared to the other eye. Her vision was fine, and there was no signs of optic nerve compression. Pupils were symmetric, field of view was okay, the eyes moved fine, and she had no double vision. We took her CT and also MRI, but I will present the CT because it is more representative. This case was, according to the radiologist, probably osteoblastoma. They mentioned in the beginning ossifying fibroma or osteochondroma, but it was not likely fibrous dysplasia because it did not remain within the anatomical boundaries. Its origin was anterior ethmoid or frontal recess. Sometimes difficult to say, especially in large tumors. And we took first an endoscopic biopsy and then external biopsy, as the first one did not give any help. And here are the CTs from 2013. I talked with my radiologist before this session, and he remembered the case. He described it like benign looking because it has a nice lining, unlike osteosarcoma in the sclerotic part towards the orbit. And there was not much ground glass appearance like in fibrous dysplasia. And in the middle, you see the axial scans, and from up till down, and it moved in the middle into the orbit very, very much, so that the optic nerve was also bended, and in the last below, you can see how proptotic the eye was, and it was also inferiorly moved. And in the sagittal scans, you can see the heterogeneity of the tumor too. It was in the skull base. Yes. We had a surgery for this lesion, which is recommended in the literature too, but the biopsy had not given the final diagnosis, so we went to operate a benign tumor with an experienced plastic surgeon colleague. We did bicoronal approach, used navigation with bone screw. We took periosteal flap for filling and saved it for filling of the frontal sinus. We did a modified rectangular left osteoplastic flap with the orbital rim included. And the tumor was removed from the orbit with a punch, and the upper part, which was soft, or the medial part, which was soft like granulous tissue or even fluid, could be removed with a scoop and suction. Mucosa of the frontal sinus was removed, and the osteoplastic flap was placed into the sinus after this putting in the periosteal flap, and we also used flow seal. But it was, at the time, it was difficult to obstruct really the frontal sinus. But we were prepared to go again if there would be problems of ophthalmos or so. The PAD, it was osteoblastoma in histology. And we have followed this girl or woman now for 8 years. It has not grown, although there is a residual tumor, but it looks fine. And now she has no ophthalmos. She has symmetric eye bulbs at the same level. Her vision and eye movements are normal. She has a very slight ptosis, but she did not ask for repair or want repairing for that when I asked her. So this is the postoperative time last year, December. In the first scan, you can see the periosteal flap in the sinus, frontal sinus, and you can see the residual tumor, which which makes the orbit quite symmetric. And yes, there's some aeration in the sinuses. This was the last. She was satisfied with this. And I could ask the first question if I can.
Yeah, of course.
Yeah. How long would you follow up her?
I think that's a good question. How long would be the follow-up, and also how would you organize the follow-up? I think which type of imaging you would use, as you have obliterated the frontal sinus. So, but it's maybe I will give the word to the panelists. Cem.
Well, for follow-up, actually, I can. When the patient don't have any symptoms, but clearly the frontal sinus drainage is affected. So, would you not consider, to open the mucocele that formed on the left side? So, then the follow-ups can be done endoscopically. If you go from below and do a draft type 2B or 3. Through that, endoscopically, we may also drill the residual. Well, otherwise, if the patient don't have any symptoms and don't want a second operation, the follow-up, I would well, in 3-4 months, I would ask for an MRI to also see for the mucocele, so that I have another option in my hand to evaluate the area, because for this, having the residual inside, if there will be no operation, continually even if you do every year, the patient is going to be exposed to radiation. So if I'm going to follow up, my follow-up will be rather for the mucocele. And from that, I can also see the intraorbital fat and muscle, and between the mucocele and the fat, I can also appreciate if the osteoblastoma is growing or not. I don't know. These are my thoughts.
Well, it's not clear whether there's really a mucocele. I heard it's osteoplastic flap. It may be also scar tissue, but the patient has got 17 years. She's very young. And she has a life expectancy of 70 more years. So we have to think of the radiation dose, and I probably would be pragmatic and offer her to do an MR scan follow-up every 2 years or something like that. But the point here is we have residual tumor, and theoretically we could, if it grows, go back and do a more radical tumor resection. So we have to think also of this possibility.
For me, I would probably decide for MRI in 3 months to see how is the postoperative status, if there is any forming of mucocele as the previous speakers. And because of the age, I would prefer MRI to CT. Then if it were okay on the first MRI, then I would do it yearly.
So I would like to discuss a little bit the previous CT scan, the pre-op CT scan, if it's possible, so we can talk about indications of surgery. So situation like this, I think, the surgery is 2013, but I think I would propose to the patient probably an endoscopic resection. I would propose to have prepared the bicoronal approach just in case I'm not able, if there is some kind of CSF leak I cannot manage over the orbit, to far lateral, and to do a combined approach after. But I think for probably the first indication for me would be endoscopic approach, transnasal endoscopic approach. What about indication for surgery? I don't know if you think differently, you have a different option.
We wanted to be very conservative, not to do a lot of harm.
Maybe because I agree with Alkis. She's very young, and if it looks like a benign tumor, I always find the balance for morbidity versus getting out a benign tumor, but we don't know this yet. But still, that's a balance you really need to think about, including her age. So I think I agree with, I would start endoscopically, and maybe not even prep her for a bicoronal, but we have an excellent orbital surgeon, and if in any case I would have a CSF leak which I could not reach, it's probably less morbidity with a transcaruncular approach to approach it than a bicoronal excision. And then even if I'm doing this operation in a 17-year-old girl, maybe I find myself in the position that I think I cannot reach all the tumor, but it's probably benign. I already have pathology. First see what the pathology is, and then decide radical or watch and scan. Because fortunately, for 8 years already, it doesn't grow.
And we have scanned it with CT several,
much better.
A few times, so it does not have any signs of a mucocele. It's the flap inside the frontal.
You wanted to say something?
Can I ask you a question? You see, if you would do this endoscopically, that the anterior ethmoidal artery, if you look on the upper left CT scan, will be probably somewhere compressed or in between the tumor. How would you deal with that? Just look for it.
While drilling, most probably will come out and coagulate it and cut it.
And if you would have a dural defect during the surgery, how would you reconstruct?
During defect, I will do a 3-layer reconstruction with fascia lata. And some kind, maybe I can use a flap, a middle turbinate flap, but maybe most likely the middle turbinate would have gone out from the beginning of the surgery. But some kind of septal flap or a flip flap from the other side, or a Haddad flap if it can reach. Most likely a flip flap from the other side. You can resect the septum from the homolateral, the ipsilateral side, and then use the other side to cover the whole area.
Just to mention, I would try to assess its attachment, also from where it is really growing. Generally, it is more anterior from the frontal beak, and as it grows, actually, almost in all instances, I have observed that there is some kind of a very little thin mucosa between the real skull base that is also there, and then that mucosa, and then the osteoma or that spongiose part here just fits in that. So once you, it is important in an endoscopic approach to do cavitation. So as you get rid of the middle portion, from some point you start to just break the corners, especially if we go endoscopically, the ebonoid, the stronger portion, you need to really drill as much as you can, because once you break it, then you cannot drill anymore. Then that's a bigger problem inside. But in many cases, I have had the chance to really dissect from delicate skull base, because there was a little sheet there with mucosa on one side. The second, with the anterior ethmoid artery, what you have asked, that becomes actually in that area the main feeder. So I would really, I mean, now we are only seeing some sections. I would really go with through those. And if I operate today, I would use the navigation system and I would mark its trace. And even we have the augmented reality possibility. So when I'm coming nearby, it already shows within the tumor where it is. And then it is, yeah, just you can bipolar and ligate it. That's not a real big problem, but if it occurs, the CSF leak, and there is a high probability, because in the beginning you don't know where it is really attaching, then that would be really like any skull-based case that we can reconstruct.
How many hours would you book for this patient when you do it endoscopically?
That would be definitely some 3-4 hours.
Yeah, almost a day's work. How many hours did you have, Paula?
Well, we had with the plastic surgeons about 7-8 hours, and then I was left to put it back.
Okay, so it takes time. I think this
Yes,
is
it was a
message as well.
long session.
Plating and
So-
that also takes time.
You have a question or remark?
Okay.
No?
I think that talking about ethmoidal artery, most probably, as Cem said, it will be the main feeder in the lesion, and you will find it inside. So even if we hit it, I think it will not retract more because you have all bone over there. So I don't think it would be an issue to worry a lot about. Maybe at the last part, the more lateral part, it would be the right time to take care, not to hit it, but on the medial aspect, I think it would be not a big issue. I think so.
Okay.
Is there?
So, as I got the message that maybe I'll follow up because she's so symptomless, and she would probably not want any surgery at the time, and I think a few more years.
Yes, the only thing, maybe I don't know how is the MRI of the post-op, that if there's some mucopio or something, she may be at risk of having any orbital complications in the next year. So I think she
I agree.
has to be follow up
Yes.
to check out
Yes.
any of these conditions.
Thank you.
Do you think there is any need for a reconstruction of the orbit?
No. When there is the medial wall operated, and in our experience, we don't need to have any reconstruction of the orbit. If the periorbit, of course, is untouched, you don't need anything. But even if you do in the orbital resection and you remove, I don't know, like vascular lesions, hemangiomas or something, and you do some dissection inside the orbit, you don't really need to reconstruct with something. Sometimes we put some mucosa, maybe from the turbinate, just to cover and leave it there, and you have better healing, but no any bony or plates or something to keep the fat inside. You don't need that.
Another thing is to, but that is not connected to this case, that you have to look at your frontal sinus drainage. If you have a big defect, it shouldn't block.
Okay, thank you.
Thank you.
So our next speaker is Dr. Zuzana Balatkova. And I will try to give you a pointer. It will work, but it's a strange pointer. Is it working? It's not working on the right place.
Good afternoon, everybody. I would like to present you a next case of a benign tumor of fibroosseous tissue. It was a young lady, 23 years old. Her first symptom was acute rhinosinusitis with dominant symptomatic on the left side. It was only one episode, and after that, or since that, she has had frontal headache and pressure over left frontal region, which was distressing her, and she just started her studies at the university, or was continuing her studies, and she couldn't learn. And she had some topical steroids, nasal dashes, it didn't help. And she was sent to a CT scan. And with a CT scan, she came for a consultation to our department. And on a CT scan, there was a paramedial osteoma of the frontal sinus. We could also say that it was an incidental finding, but there was a small mucosal. Oops. It's not working. Okay. There were small mucosal changes in the upper part of the frontal sinus. And it was where her symptoms were. So we waited. I explained that the characteristic of the tumor looks benign, that there is probably low risk of a malignant tumor, and we can wait. It's fine. It's fine. Thank you. Here's the pointer, but it's not functioning. Oh, another one. Oh, thank you. Thank you. So we waited 3 more months, and their symptoms persevered. And we discussed options with her, if we should go endoscopically or externally. And because frontal osteum was intact, quite white, let's say, but the osteoma was not that small to remove it right away through it, so we decided for external approach. And this is how the scar looked 7 days after the surgery, after the removal of the stitches. And we did a control CT scan 4 months after the surgery. Her symptoms relieved. She had no headache since then. And we made clinical controls 2 more years. We didn't perform any other CT scan, and then she was released from follow-up.
Okay,
So
thank you.
my question is, may I, or
Yeah, of course.
if because it's a question if to do the surgery is the first question, but in this case it helped, but I usually recommend my patients to wait, because sometimes they are only anxious from the finding, but the symptoms are usually not related to the osteoma. And if anyone from the panelists would perform endoscopic resection.
Okay, maybe we start with Dr. Adriaensen. So
I'll remove the mask. To start with the start, I think you have to be very careful if the only symptom is pain, especially in benign lesions or benign-like lesions. Obviously, you made the right decision. But how long have you done the follow-up?
2 years.
Okay, nice. Because often also
sometimes it occurs later on,
away,
and the symptoms are the same.
They give you flowers, and then half a year later, they want their flowers back. So the diagnosis of acute sinusitis is not just frontal pain, but obviously you also saw some inflamed mucosa or pus in the frontal recess or anything. And the second thing is, it really looks benign on the CT, and she's quite young, so I think I would go for an endonasal approach. And even if you leave a bit, but you restore drainage and it doesn't grow,
yes, it's definitely an option.
I think that would be my preference instead of having a numb.
Yes, well, in a young patient, the general anesthesia is not that risky,
No.
but the length of the
approach.
surgery is different in endoscopic and external approach, I would say, because you have to go through. So I think endoscopic is a bit longer than external in this case.
Gwijde, how do you judge whether or not it will be possible to reach endoscopically? Because if you go back to the sagittal image, it's quite a distance you have to overcome from the anterior nasal beak.
It's true.
So do
But it
you
looks
use
really-
some kind of landmarks, or do you have something in your mind that you say on on beforehand I can judge whether I could reach it or not? Maybe you could back to the sagittal. Yeah, there.
The thing is, you would really like to have all the images, because what Jem said before, if you look at it very carefully, you have, I don't know, 0.5 millimeter slides, you probably can find somewhere where it's attached.
It was
And-
attached medially.
Where was it?
Medial.
Medial, so that's even better. But at least if I looked at this scan, I sort of guessed that it wouldn't be on the frontal wall of the frontal sinus, if any, on the posterior wall of the frontal sinus.
It was
and then,
actually somewhere.
and then
It was at the border of the medial and posterior.
yeah, and then that makes it feasible. And the anterior lump, the hard part is if it gets released, and you have this floating marble, which you're trying to get out, and you cannot,
Can grab.
it's loose, but the opening is, and you need to cut it in two somehow. But look at the attachment.
And would you use a draft 3 or draft type B, C?
I think you need a 3 eventually. Saves a lot of time.
Or 2C.
Well, that was my question, a 2C.
For sure. You don't need to open both ethmoids for this stuff.
I just think you go through the. I mean, for the OP indication, for me, it clearly closes upstairs, and it can make recurrent problems. So you can give antibiotics and look forward, but then she waited for 2 years, and still the patient had problem. Then that's. Yeah, that was the question. So for me, the OP indication is okay there, but due to the, exactly as you told, because of the, lady, young lady, I would try to give a try from below, and I think the only thing that we should be really caring is that if I leave only a small portion at the posterior table, frontal table, and then get everything and it's aerated, that would be enough. That would be the only thing that we should look. And if you do a type C, 2C, then you still have the natural normal drainage, and then it would be. But 3 is also fine. But as this is actually not an inflammatory disease, with using some flaps to cover the bone that I drill, I would not really expect a failed draft 3 in that one, even if I go for a 3.
I think resection endonasally, if you master draft 2B, 2C, or 3, is an option. But it takes time, and it needs good instruments because it's quite far away. So you will be drilling. How much would you plan for this case, Jem? You're a master, but you will plan 3 hours, 4 hours. Yeah, I think the external approach was also a good decision. It's not wrong to do it.
We had also a similar case which was removed endoscopically, and it lasted more than 3 hours. This lasted 20 minutes or...
Yeah, it's
so
straightforward.
It's also the point.
It's straightforward, it saves time. The transpalpebral scar is okay, usually. Theoretically, in a woman with a lot of hair, you could even think of a good coronal approach. It would not be wrong either. But I think it was a good solution for this case. And maybe when you leave a little bit of the tumor, there's also a psychological aspect of the patient. You tell them, well, I solved it, but there's still a little bit of a thing in there. And most patients could cope with that, but I met some patient who cannot live with a tumor, even if it's benign, even if it's not dangerous. They want to have the tumor removed. So you just have to keep this in mind.
Exactly. Thank you.
one question for me. If you accidentally happen to injure the posterior wall of the frontal sinus and have a CSF leak, how would you manage it endoscopically? What would be your...
I mean, if I'm there with the endoscope, I would manage it endoscopically. If I'm coming from up, external approach, then it's, yeah. But it is doable.
Yeah, question from the audience.
Using this approach you used, what about the supraorbital nerves? Were they resected? Did the patient have numbness after surgery?
Well, actually, we identified them during the approach, and we pushed them medially, and they were not restored.
Okay, perfect.
Preserved.
It's always a risk
yeah.
on that approach. Okay.
I would like to ask my colleagues if anybody would consider a transorbital external transpalpebral superior lead approach to the frontal sinus. You think it could be an option in this case and save draft to B, C 4 hours? So instead of going supraciliary, going through the orbit and going up to the frontal sinus.
Yes. Still, if this was more lateral, I would do. This is too medial for me to think about. I would. That's the reason I thought endonasally. But if the sinus was more aerated and this was sitting more lateral, that's a really very good option instead of having the cut there. It's the blepharoplasty incision is none. I mean, this also heals perfectly. I mean, we have done tons of them earlier, so they heal perfectly. But the other one is better. It's almost an aesthetic operation.
Can I ask you a question about the follow-up? Do you think if you would approach it endoscopically, then of course you open up the frontal recess maximally, would that help you in the follow-up or not?
Yes.
Yes.
Yeah. As if this is an added value or not, that you can inspect the sinus with flexible or rigid endoscopes or not? So it's just a question.
Yeah, for sure. Although if you have some residual disease there left, you have to follow it, of course, radiologically. And then when the mucosa is healed, and okay, if you don't see any bulging, you think it's everything okay. But maybe some time you may see some kind of bulging and you may need to do radiology examination again. So it's not a mucosal disease like inverted papilloma, so I see something that the mucosa is different and I can change. This is below the mucosa, so if you have the bulging, maybe you think you have to do some kind of radiologic examination. Of course, it's an added value to have the frontal recess open, for sure.
Maybe if I can, maybe also the location. In this location, the wide opening would help in the lateral part of the frontal sinus if it were located elsewhere. Even the endoscopic view might not be that good, even after opening.
Just for discussion, I like to, if it's benign, you took it out, there are no complaints, only follow up with complaints.
What do you say? Only follow up?
If complaints.
If complaints, okay.
Yeah.
Okay, thank you.
Thank you.
Cem, that's up to you. Otherwise, we already have a lot of osseous lesions. You want to show it?
Okay, let's go fast. Otherwise, that was my only lesion. So.
Okay, sorry.
So I'd like to remind the next conference next year. So that's a 46-year-old male with symptoms of frontal headache, visual problems, proptosis, predominantly, and over the years growing hard mass at right medial canthus region. and had no history of previous head trauma or surgery, and the examination you can palpate of a right-sided orbital heart mass superior to medial canthus. And we had a high-resolution computer tomography, and that was the portion here actually. Okay. I cannot show this. Okay. That you can feel from outside. So that was again a osteoma with more ebony part and spongiose part. But for us, the problem was that it was obstructing the frontal sinus inlet, but also sphenoid sinus at the back, and also getting into the orbit and really inside pushing and causing the proptosis of the patient, and probably here around this level, you see this might be the anterior ethmoid artery that becomes really the main feeder. It really grows big in those cases. So that was the MRI, because we wanted to see what's happening into orbit. So these were the MRIs, and clearly you see the frontal sinus is obstructed, as well as the sphenoid sinus at the back. And the periorbita was probably intact, and generally it is intact. It pushes in. So this was the osteoma of the sinonasal cavity, compression on the globe, medial rectus muscle, and at the back to the optic nerve, as well as causing the cosmetic problem due to proptosis, apart from the drainage obstruction problems. So an external approach could be also used in this one, as it is really going very anterior, so from the skin you can really feel. Or an endonasal endoscopic approach can be used, a draft type 3, then watching out the skull base, ethmoid arteries, CSF leak sphenoidotomy. This is from the anatomical dissections, so it generally heals perfectly later on, the incisions. But as you don't really come from down, the flow is generally impacted and could end up with the mucocele, and you may really need to sacrifice the supraorbital nerve. So in this portion I cannot. Okay, perhaps I can. Is it? Okay. So we are coming to the tumor, and then before draft 3 we prepare the flap, laterally attached, and that comes down, and then we do the draft 3, and that was the mucocele outside. It's sucked, and we continue and reach down, and this is in the tumor we are drilling. It is, everything is gone from the medial part. This is the periorbita portion. And as we do the cavitation, we are thinning the ebony part at the back. This is the very posterior part. And it takes some time naturally, but you can see, this is the posterior ethmoid artery. You can really dissect it from the skull base. This was in the sphenoid sinus, and as you come anterior, thinning, and then it starts to move, and from itself, this is the skull base at the top, and then you can dissect. This is the olfactory philia. Here then the skull base is intact, and as you can see, there is some mucosa in between, and this is the very last portion, getting anterior. After the detachment, and then we can really complete the draft tree after opening and put back our flap. And some fibrin glue, and we put this stem for the flap so it stays for 2.5, 3 weeks. Oops, okay, this is somehow blocked. It's not, okay. So this is the post-operative CT. This is in the first month, and this is the post-operative first month, the healing. I just wanted to show the very early healing. The flap really covers the bone, and there are some polypoid tissues, but they also go away. But the real drilling area is well healed. And this is the postoperative 9th month. As you can see, it's nicely the frontal sinus, and this is the sphenoid sinus, and you can really appreciate. So here generally, if the periorbita is kept intact, it is no problem, but I just wanted to show this one. In this case, the periorbita was not intact, so this is generally something that we don't see. This was the external portion, and after removing that, you see there was a little dehiscence, and through this little dehiscence here, it grew inside the periorbita. This is something that we don't really normally see, and then we need to then dissect intraorbitally. So this is also not a big problem. But this is the intraorbital portion. So this you cannot drill and cavitate in the orbit. So this was the postoperative of that second week. So thank you very much, and you're all welcome to next year's meeting in Milano. So any comments about the case? So I can go back, or no?
Did you expect the intraconal lesion on beforehand, or was it something that you noticed during the surgery?
That in the second one.
Yeah, in
the second one, I was not expecting. I was expecting like the first one. Yeah. So once you start to drill, you find the periorbita, and when you remove, everything is intact. But in that one, you needed to. I mean, that was some 15 years ago. Actually, that's the quality is bad. But later on, I haven't seen such a thing. So they were all out. But that was breaching the periorbita. So I just wanted to share.
I have a question for the panelists about, again, the frontal. Would you consider doing not a draft tree in the first case, the first patient? Or would you say, what are the arguments pro and con to do a draft tree over there? If it's overkill or not, or You want to have this maximally open neostium?
Basically, I would follow the lesion.
Yeah.
So I tell the patient that I was prepared to do it, but only if necessary, and then start decavitating and piecemeal taking it out. Sometimes also the use of a crake, the forceps you can really crush, really helps, because it makes into small pieces and it saves a lot of drilling time, because this is very nice surgery, Jem, but how long did you work on it?
Yeah, but I mean, even if you go from outside, that will take time.
Always.
Because up to the level of sphenoid sinus, optic nerve, you have to really dissect. But the thing why I've done the draft 3 is actually the reason it was really coming way too anterior up to the level of the frontal beak. So I really get scared if it is really attaching there and I have a CSF leak. I want to have a better control by doing the draft 3 right from the beginning. So I mean exposure, because of the exposure. And also I thought that I will anyway get rid of the medial wall of the frontal sinus, then I can only have advantage in that case. So that's anyway a long case.
Exactly.
Jem, I would like to ask you one thing. It's not the case, but sometimes you have the attachment of the lateral lamella of the cribriform plate, so it's very fragile and it's side of CSF leak. Do you think it's acceptable to leave a small piece over there at this site, or you have to drill and have CSF and repair CSF? What do you think?
Very good point. It's like the case that Zuzana have shown. Then where it is dangerous for such a benign disease, I try to leave. And my intention in this case was also making it thin, and leaving some portion there. But as I make it thinner, in the case you have seen, it started to move by itself.
Yeah, of course.
At that point, then when it starts to point,
not
then
in this case,
moves
but
itself,
because to see the CT, you can say that there is some kind of involvement of the cribriform, and the CSF leak could be.
That's I wanted to say. Actually, it seems that it is all attached, but almost in many cases, I can confirm you there is a small mucosa there, and if you make it very thin, it falls down.
Yeah, I agree completely.
This was a good question or comment, and I personally would not hesitate to resect the bone of the cribriform plate and then cover the CSF leak that you will face, because over the years I'm familiar with closing CSF leaks. It's not a big deal. It's easy to close, and then you have solved the tumor. And but of course, it depends a little bit on your experience or on your confidence. But as a basic rule, I would try, even if it's a benign tumor, to resect it completely. Of course, you have CSF leak, but it's not really difficult to close it. And it probably depends on your personal confidence and experience. This is at least the approach that I have nowadays.
Okay. Thank you, Chairman. You're welcome. So it's somehow blocked.
It's blocked. Oh. Okay, that's not good, huh? Okay, we go to another type of pathology, and as Apostolos has not presented yet, I think for the remaining 50 minutes we give the floor to you.
So I try to go fast. So this is a male of 64 years old, and his past medical history, he's an occasional smoller, he has some allergies, he suffers from high blood pressure and he takes drugs for that. He had 2 previous surgeries for chronic rhinosinusitis. He had 2 FES, in another medical, in another hospital. So he came to our attention because he had, he referred the unilateral nasal obstruction, some orbital ache, some kind of epistaxis coming and going, and he was using frequently antibiotics prescribed by his medical doctor. So in this case, we performed this CT scan because on the endoscopy, I have the endoscopy only, sorry, like this. I can show you this lesion coming out from the middle meatus and on the right nasal cavity. So unilateral lesion. The protocol is to do always a CT scan as a first time diagnostic examination. And we find out this kind of situation. So what we look like, we're trying to find out if there is any signs of osteitis or any bony spurs or something that can give us the suspicion of some benign lesion. Of course, it's the round table. And most likely this is the spur we are trying to see. And this gives us the suspicion of on inverted papilloma. So do you think in this kind of situation is necessary to have an MRI? Although we are not have any orbital invasion, we don't have any, but you will require an MRI. Yeah, we do so. So MRI gives us more information regarding the tissue, and we have the convoluted cerebriform pattern of inverted papilloma, and you can see clearly the site of attachment coming from the bony spur on the anterior lateral wall of the maxillary sinus. So we did histology. Histology was an inverted papilloma. And of course, surgery was indicated. Before showing you the video, I would like to ask you, in such a case, what would be the option that you would offer to the patient, if I can ask you, and then of course I show you what we did. Do you think you start with Denker's approach, medial maxillectomy, removing all the medial wall?
I would go for a modified medial maxillectomy, leaving the nasolacrimal duct system intact, and we have a nice type 3 prelacrimal window in this case.
So you would go for prelacrimal approach?
Prelacrimal maybe combined with postlacrimal sinusotomy type 3.
Would anybody do something different on the panel? So what we did was a prelacrimal approach, as Hans told us, and video is not.
It work. It's
No, it's not. So we always nowadays start, if we feel that the medial wall is not involved by the tumor, we always start with the prelacrimal, but I have to say that even if we think that it may be involved, we try it the same. We start with the prelacrimal approach, so meaning we do an anterior incision in the front of the head of the inferior turbinate. We release the inferior turbinate, the mucosa, and then we do the osteotomy. Anterior osteotomy anteriorly to the lacrimal duct, and then we do a fracture of the medial wall, and this is the mucosa of the medial wall of the maxillary, and we enter the maxillary sinus. You see this is the mass. You can see the normal mucosa behind. This is the feeder of the lesion, or a small vessel at the beginning. Something happened over here, okay. And this approach is very nice because you can see all the mucosa that is involved and do the pedicle-oriented surgery. So follow the tumor with the debulking, with the shaver. You see what is the point, and this is the bony spur that we have to drill, and there is a feeder inside. So I was saying that it's a very nice approach that permits you to selectively remove the mucosa inside the maxillary sinus and have less morbidity for the patient. This is the infraorbital nerve over there. And you get a good control in the post-op because this is the end. You have already a middle antrostomy done, and you can follow inside the mucosa, even with a flexible endoscope if you need. And the patient has less harm. But there are some critical points. The critical points, of course, is if you have the space to do it. That it means if you have, as Hans was saying before, if you have a nice window anteriorly between the lacrimal duct to access this area between the anterior angle of the maxillary sinus and the lacrimal duct. So in this cut, maybe it's not so clear, but more the lacrimal duct is anterior, less space you have to do, and you may harm the duct. More is posterior, you have a better access, a better window, you can move inside and work properly. And then the other thing you should tell, of course, your patient that the post-op, it may be the same regarding the paresthesia of the cheek and of the teeth, because on the anterior wall you will have the anterior superior alveolar nerve that if you drill the anterior wall, you will have a damaging of it. So the patient should know that this is a big issue and will get better with time, but it may feel something on the teeth. Any comments, any questions? Would you do something different? I don't know.
I think the issue you raised about the nerve is, I think, relevant. Do you discuss this on beforehand that this will be almost the case, or do you try to avoid damage to this alveolar nerve? And which landmarks would you use? It's not easy, but
it's not easy to not to harm the nerve. I mean, if you have a good space and you don't drill very anteriorly, and you can't dominate the inside the maxillary, and you don't have to drill the anterior part, you may preserve it. But if the pedicle is very anterior and you have to drill, it's impossible to save the nerve.
This is a good question, and our group occasionally did a study on that, which will come out in rhinology in a few months. It's accepted. And we looked at the landmarks, and the landmark where we find the ASEN, the anterior superior alveolar nerve, is 4 millimeter anterior to the axilla or shoulder of the inferior turbinate bone, 4 millimeter anterior, and in average 4 to 5 millimeters inferior, so anterior and inferior, and there you will find the ASEN. And so if you keep close to the axilla of the anterior insertion of the inferior turbinate, then you can probably spare this nerve.
Okay, thank you.
Okay. Can I ask? Yes. How would you operate if you could not have the right space for the pre-lacrimal approach? And then another question for another type of lesion. if it was right in the bottom of a very deep maxillary sinus, how would you operate?
So if I didn't have the space, I would go for maxillectomy because the duct it may get harmed, so the patient will have a bifora or something. You can also try to do the surgery and see what happens afterwards, and then you can maybe perform some kind of DCR if the patient has some symptoms afterwards, and not to do a DCR immediately. So if it depends how clear is the lesion at the time of surgery, I think. For a benign lesion, I think that if you have a deep lesion, you can manage with curved drills to remove the mucosa and drill it. One issue could be with ameloblastomas. Ameloblastomas, you can give a try initially with an endoscopic approach, but sometimes they recur, and then you have to resect, of course, the part of do a maxillectomy, the classic maxillectomy. But this is a lesion, different lesion, and the indications are different because they develop from the teeth.
Gwijde? Can you give the mic to Gwijde?
Can I be a little devil's advocate? Can I be a little devil's advocate on the imaging? You always do an MRI?
Yeah, almost, yes.
Because in this case, this specific case, and you also mentioned that even if you suspected it might be attached on the medial wall, you would still start with the prelacrimal approach.
Mm-hmm.
How did the pre-op MRI change any of your course faction?
It just gave me the confirmation of the convoluted pattern on MRI. Really.
You send it for pathology anyway.
Yeah.
Because sometimes an MRI is not
really
available.
It could be that maybe you may have some suspicious, some surprise like a malignant transformation, and you cannot. Okay, the CT was good. You didn't have any infiltration of the bone to have the suspicion on that. But you may have some changes inside. So nowadays there is a paper that came out, I think Mario showed you today, from the American group that shows that the convoluted pattern inside the inverted papilloma is changed, and the diffusion MRI shows you that you have less diffusion. So I think...
Still you would do the surgery.
Yeah, but maybe you would suggest or change something, I don't know.
In the post-op directly, yes. No, but just to sort of...
So maybe, I don't know, if you have some infiltration of the inferior part, you should do something combined to external also. So,
well, specifically for this case, it didn't brought, as you mentioned, too much. But for the instances that it could have brought, only to confirm and exclude them is the information actually that it brought in this case.
Yeah.
And it's nice to have still.
I have. Oh, sorry, please.
How long would you recommend the follow-up of the patient?
Follow-up? We do in our department. We are used to do 10-year follow-up at least, but also long life follow-up for patients that come back again, because many patients, they don't want to come back and they stop, and you may lose the patient because they don't want to come back. And many patients come from outside of our city. They come from South Italy or from the East Italy, and it may take a journey, so sometimes we lose them. But as long as we can follow them, we follow them. Of course, after 5 years, we do maybe after 2 years a follow-up, just to in case to see how it's doing the patient. But the first 5 years, of course, every year.
We do the same because we saw also recurrences after 8 years or before, so after a long term. So I think it's important to say.
Yeah.
I have a question for you and for the panelists about, let's say, if you have a clear pedicled lesion, would you, first of all, try to send all the material to pathology, and how would you do that? Because it's always tempting to use a debrider to, let's say, reduce the lesion to the stalk. And two, would you remove all the mucosa and do frozen sections?
So Regarding the first issue, I try to say as much as I can of the pathologist, the big piece of tumor, so it has more material to check and find out if maybe sometimes there could be some malignant foci inside. And pathologists are always happy to have a lot of material to analyze. Then once I have a good piece and I'm satisfied of the tumor, I go to debulk the tumor to do a shaving. Somebody in the past, I think, was suggesting to do the sampling of the container, of the suction, of the blood and everything, and to do filtration, but it's something I think impossible and nobody is doing. And you're doing? Yeah?
And your pathologist is still happy?
We do it, also for pathology training purposes, and then we write insides of the shaver pot. Please analyze everything. And then especially if you during surgery you feel like it's too bloody or you have too many perforators, or then we actually say we go to them, tell them to really look at it. Just a filter.
Who is doing the job?
Who? The pathologist.
So you give them...
Oh, no, the nurse.
The nurse inside?
Yeah, it's at the end of surgery, they don't like it. But you just sift it through.
Yeah. So regarding the
2 minutes.
Second issue about mucosa removal, if it's something like this pedicle around the mucosa, around the lesion, around the pedicle, just selective resection, and the issue could be when the pathologist may not be there at the evening or the afternoon. So I could be a little bit more aggressive if I see some mucosa I don't like a lot and take it out. And many times came out that it was just only inflammatory mucosa and nothing was over there. But if I have the pathologist, I may take a sample and send it just to be sure. And
Somebody else the same ideas or experience with this? To do frozen sections or remove the mucosa completely?
So it depends, I think, how healthy you see the mucosa. So if it's a nice mucosa lining and with the shaver the tumor is coming and it's just sitting there with no any evidence of infiltration, I think could be, at least in our experience, it's working.
Well, I cannot really give so specific data, but the imaging system that we are using have some filters, so spectra A, spectra B. So we have been really using that technology for many instances. Actually, during the surgery, if we can really differentiate from normal mucosa to unhealthy mucosa, and I mean that gives an extra layer of, on-site feeling that I cannot really scientifically say anything, but generally because that spectra B takes all the red out, and with the clarochroma, you have better contrast and lightening, but with that spectra B, you can even have the feeling that you're looking through the mucosa to the vasculature pattern. And generally, if it's an emergent papilloma or squamous cell carcinoma or any other tumor, so just for research purposes, we are just trying to get scans of that scene. But during surgery, while we are having the dissection, if we have any question mark, we just turn on that and have a look. So.
Sometimes it's very difficult to distinguish between inflammatory changes. Around the tumor you have blockage of secretion and the mucosa is inflamed, and it's sometimes very hard to distinguish between infiltration of tumor and inflammatory changes. And in doubt, what we want to achieve is to prevent recurrence. So in doubt, we need to take more. And of course you can map the resection, but you want to have a complete resection on the first time. Yeah. So I would rather go to be more generous than to leave something behind. And frozen section, if it's available, it's not a bad idea, but it's not always easily available.
Okay, I think we should come to an end. We're a little bit over time, but it's no problem because it's a break. I would like to thank moderator, Professor Thibaut von Celle, and all the panelists, and thank you for watching.